Hello, and welcome to this series of Education for Health on cardiovascular health, supporting World Heart Day. My name is Preeti Minhas, and I'm the Assistant Director of Clinical Learning at Education for Health. And today we'll be discussing the burden of heart failure in the UK. I'm delighted to be joined by our guests today, Louise Clayton, who is the co-chair of Alliance for Heart Failure, and Jim Moore, who is a GP as part of the steering committee for Alliance for Heart Failure. Welcome to both of you today. And if I could start with a couple of introductions, a little bit more about you and your roles.
That's great, Preeti. Thank you very much for the introduction. So I'm Louise Clayton. I'm an advanced heart failure cardiac practitioner and service lead in Leicester and Leicestershire. So I've been working in heart failure for 22 years now. So definitely a topic close to my heart.
Great.
Thank you for the introduction, Preeti. And it's always a great delight to be in conversation with Louise, which we've done many times around the topic, as Louise describes, close to her heart and to mine, that of heart failure. So I'm Jim Moore. I'm a GP in Gloucestershire, but I'm also a GP with an extended role or a special interest in heart failure. And I work within the Gloucestershire Heart Failure Service, which will celebrate 20 years of delivering heart failure services next year.
So we're both aged, is what we're saying.
A lot of experience then. Thank you for joining us today, and it's great for our listeners to be able to hear a lot about that experience and really to start to explore how we can really deliver quality outcomes for patients in heart failure. So I guess it'd be great to just look around the burden of heart failure in the UK. So what is the impact of heart failure on whether that's hospitalizations, NHS expenditure, mortalities?
And that it's a really important area to lay the foundations of any discussion, because Preeti, as we discussed just a moment ago, that the visibility of heart failure across primary, secondary, and tertiary care has not been as we would wish it to be over a number of decades now, and it's only in the last 5 years, maybe 10 years, for various reasons, that heart failure has begun to find its way up and onto that national agenda. And from a national perspective, it's very much part of the cardiovascular agenda from an NHSE perspective. It's quite surprising if you're not familiar with the burden of heart failure. If you look internationally, initially, there's across the world estimates around 26 million people with heart failure worldwide, and we know in terms of healthcare expenditure or costs. Again, from a global perspective, it's somewhere around 1.5 to 2% of those costs. If we look closer to home, which is always important because health care, the delivery of healthcare internationally, globally varies so much. We've probably got somewhere around 1 million people with heart failure. And when you look at how that affects our population, somewhere around 1 in 5 people over the age of 40 in their lifetime will develop heart failure. Part of the reason that we're also seeing an increase in the incidence, the number of cases of heart failure that are occurring year on year, is that people are surviving some of those acute events, cardiology events, that befall them typically in later life. So, we've become very expert at treating people who have who have heart attacks or acute myocardial infarctions. But one of the consequences of that better delivery of acute care is that we're seeing more people who survive and ultimately may develop heart failure. And the other kind of reflection is if you look at any of the disease processes within cardiovascular disease, there's one place that they tend to end up, and that's with heart failure.
Yeah.
Costs in the UK, about 2% of our budget, which is somewhere around 650 million. And importantly, and Louise and I will probably explore this in a bit more detail, 3/4 of that, maybe 80% of that sum of money is on hospitalizations related to heart failure. And in fact, we need to be shifting that in the opposite direction towards early diagnosis, because we know the outcomes are so much better if we can diagnose people early and, where it's appropriate, get them on the evidence-based therapies. And I'm sure Louise is now going to tell you about her kind of experience at that front end and early diagnosis and the important role of primary care.
I think that's absolutely key, isn't it, Jim? And I think, what still surprises me to this day is the complete lack of awareness around heart failure. We have so many national campaigns for so many other conditions, and these triggers that are sort of, we talk about red flags, things that make people sort of sit up and worry about their health, and we just don't have that in heart failure. And I've never really quite got to the bottom of why, but when we talk about the budgets and the burden and the costs, and thinking about the costs to our patients, costs to their abilities and their abilities to function within society. When we look at the fact that heart failure is more prevalent than the 4 most common cancers, people don't understand that. They can't quite equate that. And I think this is something that we really need to address and get this message out to people. What is it that we're talking about when we're talking about heart failure? Looking at the signs and symptoms, things to look out for. So breathlessness on exertion, fatigue, and these things, like you said, Jim, it's complex in some ways because they are non-specific. These symptoms can be related to lots of other conditions. But, maybe that's not just the end of the story, is it? Actually, if somebody is presenting with some of these other health problems that a lot of heart failure patients have that you've alluded to, and then they're telling people that they are sort of having problems with feeling more breathless or more tired, for example, or any sort of feet or ankle swelling, we really need to get this message out there that people think heart failure. And is this a possibility that this is a problem? Because as you've just said, 70 to 80% of these costs for the NHS budget are around hospitalisation. And actually, what we do know from talking to patients is that 80% of diagnosis of heart failure happens in hospitals. But when you talk to patients on a daily basis, you do this, I do this, they have had these symptoms for a number of weeks before they get to the hospital. And, there are challenges about getting people seen in a timely fashion, as you say, whether it's about getting them to a specialist or just getting them to somebody who thinks heart failure. And also it's about making sure that the public know about heart failure so that, they can help us out. They can come and say, oh, I heard this podcast, or I saw this advert, or something that sort of triggers that thought process. And that is where primary care is absolutely key. GPs, practice nurses, the healthcare professionals out there that are seeing these patients in other clinics, might be a diabetes check or a hypertension review. And actually thinking about heart failure at that stage is really, really important. And I'm sure you'll have plenty to say on this about how primary care should and could be engaging, and maybe thinking about one of these simple tests that we talk about a lot might be something you want to talk about.
No, absolutely. But I mean, my sympathies to an extent are with primary care, because just as you described, Louise, the symptoms that people typically present to us in primary care are what we call non-specific symptoms. They occur in lots of different conditions. So breathlessness, or noticing that you're getting more breathless, going up to the local shop, or swelling of ankles. Again, there are many reasons why people have swelling of ankles. And the third in that triad of cardinal symptoms is fatigue. And, you know, talk to healthcare practitioners in primary care, and they will tell you fatigue is a terribly common thing. And I suppose, having been an ultimately, we would in some way land or, you know, talk in or link to COVID in some way during this initial podcast. But I think when symptoms such as breathlessness are presented in primary care, there's almost been a knee-jerk reaction around, think respiratory, think, you know, could this be some form of chronic lung disease, COPD, which is terribly common? Could it be some form of infection? And you and I will see referrals that we receive from primary care. Not uncommonly, patients have had a number of courses of antibiotics, and then the healthcare practitioner who's looking after them has that penny has dropped. I wonder if it could be heart failure. So we need to. It's one of the differential diagnoses of breathlessness and ankle swelling, and we almost just need to increase its visibility, make it more obvious, something that you think about earlier on. Not least because of the subsequent downstream options, which I'll come to in a moment, but also the test, that simple blood test that we describe. So it's a measurement of something called NT-proBNP. It's a chemical that's secreted by the heart in an increasing concentration when the heart's struggling a bit to cope. And it's a really good way of telling you whether someone might have heart failure or whether it's very, very unlikely that they will. And we know that access is, certainly to primary care across the country, is very, very good. We talk a lot about NT-proBNP, and it used to be that we would say, but we know that most, many people, not most, but, a number of areas of the country don't have access to it. But the most recent data that we have would suggest that it's not far off universal. But when we look at the actual use of NT-proBNP as a sort of screening test across the UK, we see a 40-fold difference in the use of this blood test, which tends to tell me that in some areas, people are thinking heart failure, and in other areas, people are not thinking about heart failure. And why is that early diagnosis important? Well, first of all, the data tells us that there are significant delays in making diagnosis. Sometimes, some of the studies that have been published suggesting it's taking over a year, 1 to 2 years before people get the diagnosis from the time that they present. And also, again, there's somewhat been published that show that although we have clear national guidance around how we should be referring and what expectations we should have in terms of subsequent assessment and investigation for people with heart failure. Again, we know that less than half the people who present with heart failure are actually going through a pathway that's nationally recognized. For instance, the NICE chronic heart failure guideline. And lastly, why is it important that we have an early diagnosis? So if you look at two different populations, if you look at the outcomes, the median survival for a population with a diagnosis in the community early, compared with those who have a diagnosis made acutely in hospital, you're going to survive twice as long if you have your diagnosis made early in the community. With all in many cases, we'll be able to get evidence-based drugs on board. We'll be able to encourage the heart to repair and to remodel and recover some of its function. And that's why it's so important that we make that diagnosis happen.
I think you touched on a really important point, and we can't get away from the COVID in the room. We know when we've looked at the national data, as you say, that heart failure admissions dropped by almost 11% in 2021, and We know that waiting lists for those gold standard diagnostics, so once they've had their NT-proBNP, if it's elevated, the pathway, as you say, goes on to say that they should have an echocardiogram. And this is quick, this is from NICE guidance. If the NT is elevated above 2000, then, they need to be on a 2-week wait. This is important. This is as like a cancer wait. 2 weeks is when these people should be seen by specialists. But if we know there's a combination of big backlog of waiting lists to be diagnosed with echocardiogram, and we know that admissions had dropped off during that period, that almost says to us that there's even more burden out there, the undiagnosed. And this is why we need to act, and we need to act now. And I think, as you say, that the key part of this is that we know there is a lot we can do. And for the audience today, I guess the first thing to do is make sure that we've got some integrated pathways, that primary care, secondary care, tertiary care, specialist services are all talking about heart failure. Getting it on the agenda is absolutely key. And I think, that's the message we want to get out there today. And I think also it's about those next steps. And I think having a really positive outlook for things that we can achieve. So there will be a podcast 2 coming soon. And I think, we know there's a big burden. We know this is a disabling condition. We know this is not a good situation that we're in. But as you've just alluded to, we also know there is a huge amount that we can do to improve quality of life and outcomes for heart failure patients, and that's key, absolutely key. And we've got a good armory there that we can use to help people. So I think on a positive end to the podcast, potentially we can look forward to a positive heart failure podcast of how we can sort of get things better next time. What do you think, Jim?
Absolutely, and certainly from my perspective, and as you're aware, Louise, I dabble in the kind of national CPIP pathways and involved in some of the heart failure work that's going on there. I am being exposed to change within care and enthusiasm, and there are many potentially exciting bits of work going on. So both you and I are aware of initiatives such as managing heart failure at home, encouraging people around self-care, educating our patients so that they're aware of their condition, so they can help us to manage their condition, which I think is really important. And also, touching on those evidence-based therapies, not only will they allow you, when we look at survival, it's much better on evidence-based therapies. People feel better on these treatments. Their quality of life improves significantly. So despite the fact, Louise, that there are some gloomy things that we've shared there, and we've described areas where we, for want of a better description, we could up our game. There are many positive things happening in heart failure, and I think we can look to the future optimistically in terms of how we can support those programs of work moving forward.
Could not agree more. Absolutely. Look forward to next time and our positive outlook.
So you heard it here today, folks. You will hear another podcast too. And I just want to say thank you both for sharing both of your perspectives from primary and secondary care. But I guess most importantly around how we can work together, have those integrated pathways to really identify early diagnosis to deliver positive outcomes for patients within heart failure. So thank you again to both Jim and Louise for coming on this podcast. If you'd like further information around some of our courses or around some of the other podcasts that we've done as part of World Heart Day, please visit our website on www.educationforhealth.org. Thank you very much.